In this video, we'll discuss G6PD glucose 6-phosphate dehydrogenase deficiency, its causes, its transmission, pathological features, and the treatment. The G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, also known as Favism. Why Favism? Because it may be caused by eating fava beans. So glucose 6-phosphate dehydrogenase deficiency is one of the most common inherited disorders. 400 million people are affected from the disease, and more than 10% of African people are affected with the disease. It's an X-linked disorder, affects the male. Females are the carrier, but homozygous female may suffer the disease. Most of the people are asymptomatic. And why does it occur? It occurs due to oxidative stress that causes symptoms of the disease. Why oxidative stress causes this symptom? Because RBCs are vulnerable to oxidant stress. What's the function of G6PD? In the RBC, G6PD is attached to the beta chain of the hemoglobin and prevents oxidative stress. It also shifts the oxygen hemoglobin dissociation curves to the right, so increasing the availability of the oxygen to the tissues. How does it prevent the oxidative stress? In shunt pathways, G6PD converts G6P, glucose 6-phosphate, to 6-phosphogluconate. In this reaction, NADPH is formed. Then this NADPH gives its hydrogen atom to the glutathione and converts it into a reduced form of glutathione. G6PD converts NADP to NADPH, and that NADPH reduces glutathione. In the absence of G6PD, reduced glutathione is not produced and tissue goes into oxidative stress, leading to hemolysis and decreased oxygen deliveries to the tissue. Oxidative denaturation of the hemoglobin is the major cause of hemolytic anemia in G6PD deficiency. Why G6PD is critical to prevent oxidative stress? G6PD is critical because it's the only source of reduced NADPH, which reduces glutathione. Glutathione prevents the oxidative stress of the cell. Why G6PD deficiency is more common in Africans? It's a protective mechanism. Falciparum malaria was common in Africa and Central Asia. Malarial parasite cannot lodge in a RBC which have oxidative stress, so it causes hemolysis, anemia, and hemoglobinuria, jaundice, and unconjugated hyperbilirubinemia. Genetics of G6PD. G6PD is an X-linked disorder, and it typically affects males. Females are the carrier. Males are homozygous to the disease. They have only one X chromosome, and that is affected. The affected father with XY chromosome does not transmit the disease to the male children because he donates them Y chromosome. Affected father transmits the disease to all his female children, so they will be carrier. Carrier females are heterozygous. They have one normal and one affected X chromosome. So this is one normal and one affected red one. Affected mother with one abnormal and one normal X chromosome can transmit the affected X chromosome to how many children? To 50% of her male children. So 50% of the male children will suffer the disease and 50% will be normal. Affected mother can transmit to how many female children? The affected mother transmit the disease. The affected X chromosome goes to 50% of her female children. So 50% of the female children will be the carrier and 50% will be normal. When a female be a homozygous, rarely a female may be homozygous. If she has an affected father and a carrier mother, then she will be homozygous. Female child of an affected father and a carrier mother will have this two abnormal X chromosomes which are affected with the disease. How severe the disease can be? It can be mild, moderate, and severe depending on the enzyme activity. In a severe form, less than 10% of the enzymes are normal. In a moderate form, up to 60% are normal. In a very mild form, up to 90% may be normal. So what are the precipitating factors of the disease? Precipitating factors, mnemonics is IMF: infections, medications, and Favism. So what are the common medication that may precipitate the disease? Mnemonics is SAN: sulfonamide, antimalarials, nitrate, and Dapsone. So which sulfonamide? Sulfamethoxazole, which is a part of the cotrimoxazole, which is very commonly used drug. This may cause hemolysis. The other part of the cotrimoxazole is trimethoprim, which is folate antagonist that may cause megaloblast. Which anti-malaria may cause are the precipitating factor? Primaquine and chloroquine are the most common. Nitrates and nitrofurantoins. Dapsone, which drug used in GI tract can cause an episode of G6PD hemolysis, that is metoclopropamide. Majority of the patients are asymptomatic. What is the triad of symptoms of hemolytic anemia? Features of hemolytic anemia are triad of symptoms are normocytic, normochromic anemia, reticulocytosis, and hyperbilirubinemia. The symptom begins with weakness, abdominal pain, jaundice, dark urine. When the condition is abrupt, Favism injection causes abrupt onset of the G6PD deficiency in neonates. Neonatal jaundice can be very severe in G6PD deficient babies, especially those who are premature and have infections and other factors like naphthalene or camphor balls in their bed. So what are the complications of neonatal jaundice in G6PD deficient neonate? It may cause kernicterus. And what's kernicterus? Deposition of bilirubin in brain. In which part of brain? In different parts of the brain, mainly in the basal ganglia, hippocampus, substantia nigra, and brainstem nuclei, causing brain damage. So what are the lab findings in G6PD deficiency? There is a rapid decrease in hemoglobin and RBC count, increased reticulocyte count, increased unconjugated bilirubin leading to jaundice. There is decrease to absent hepatoglobin. Why decrease to absent hepatoglobin? Because hemoglobin in the blood combines with hepatoglobin. Anemia is usually normocytic, normochromic, hemoglobinemia, and hemoglobinuria. What are the features of extravascular hemolysis in G6PD? The extravascular hemolytic features are high LDH and unconjugated bilirubin. What the blood film shows? Blood film shows anisocytosis, polychromasia, and spherocytosis. What's anisocytosis? Anisocytosis means variation in RBC size, microcytic, normocytic, or macrocytic. And what's polychromasia? Polychromasia occurs in hemolytic anemias. RBC are multicolored in polychromasia. They have a blue-gray discoloration, and there is increased erythropoiesis in polychromasia, and spherocytes are round RBC. Most typical feature is the presence of bizarre poikilocytes. Abnormal shaped RBC have unevenly distributed hemoglobin, hemighost. What's a poikilocyte? It has a abnormal shape, sickle shape, spherocyte, schistocytes, target cell, and the RBC may be bite cells or blister cells. Bite cells are fractured or denatured RBC. We may see Haynes body. What are Haynes bodies? Haynes bodies are denatured precipitated proteins in the RBC. Oldest and G6PD deficient RBC are destroyed more than the young RBC. Diagnosis is done by analysis of rate of NADPH production from NADP. And what's the most serious complication? Acute renal failure. The treatment of G6PD deficiency. Avoid exposure to triggering factors or precipitating factors. Not eating fava bean in G6PD deficient patient. Number 2, blood transfusion for severe anemia, hydration of the patient, hemodialysis for acute renal failure, immunosuppressants may also be given, and in severe cases splenectomy to reduce the RBC destruction. Treatment in newborn babies. Newborn babies who suffer from hyperbilirubinemia, they are treated with phototherapy and exchange transfusion depending on the severity of the disease.